you're started. Now it's recording the picture and it's recording the sound. And I can tell you that I just leave this thing sitting here, and even if I walk over the far corners of the room, the sound picks up just fine.
And you just connect it, you plug in to get it to show on the screen.
Right. Yeah. And then let me stop this. And this is the lecture on blood vessels. I don't think we'll get through it in one day, but we certainly will in two, which leaves us one last day next week for the lymphatic system.
And then 2 days next to follow.
And that's it. That's the end of the lectures. And then the final exam is the following Tuesday, right? It'll be during the same time and place that we meet here. So it'll be at 3 o'clock. I don't know if it'll be in this room or if it'll be across in one of the other labs at 3, but it'll be same time, same place. And there'll be a sign on the door if it's over there. And then following that, we'll do the practical at 4:30, like usual. And then you'll be done. Okay, so here's the next to last chapter, the blood vessels. And, I think Melissa always tells me that she always tells you guys that you got to watch me on those blood vessels because that's what I used to do a lot of. I did a lot of vascular surgery, and so I kind of like the blood vessels. That's a true statement. They're pretty easy, though, and we'll talk about it. So we've talked about the blood, which is the stuff we pump around. We've talked about the heart, which is the pump that makes it move around. And now we're going to talk about the pipes, okay? The blood vessels. And how does the blood, get around? That's not working well. It would really help if I would put the thumb drive in the computer.
Isn't that your one?
That is.
Kind of cute little puppy.
That's Elvis. Elvis the dog out on the Deschutes River and around. All right, so here's the things you need to know about blood vessels. You need to know that arteries are defined as things that carry blood away from the heart. I've already mentioned that before, but just know that. Arteries split and split and split, and then they become what we call arterioles. Now, arterioles are really important because they're kind of the controllers. They control where the blood flows. Example, when you're running marathons, you don't need to send much blood to your stomach because digestion can just wait, okay? And you don't need to send much blood to your kidneys because you can just hold on to all that fluid. You don't really manufacture any pee while you're out there running. So it's the arterioles that kind of clamp down. The arterioles have smooth muscle in the walls of them, and they clamp down and prevent blood, or at least prevent a lot of blood, from going to the areas that you don't want blood to go to. Arterioles are also important because when they do clamp down, they increase your blood pressure, which is also important sometimes. Okay, but beyond the arterioles, when it gets smaller and smaller, they become capillaries. Capillaries are the smallest blood vessels. Usually they're small enough that the red cells have to line up one by one to go through them. You remember those things called rouleaux, those stacks of red cells that stack up to get through the smallest capillaries. But also remember that the capillaries is where the action happens. That's where the capillaries give off their sugar to all the tissues around the body. It's where they give off the oxygen that they picked up in the lungs. It's where they pick up the carbon dioxide and any other waste products. That all happens in the capillaries, and then they're carried back, and the body gets rid of them. As the capillaries get bigger and bigger, we call them venules, which is nothing more than little veins. And then as they get bigger and bigger, we call them veins, and they carry the blood back to the heart. Okay? Now, there's another set of arteries that carry blood to the lungs. The pulmonary arteries carry blood away from the heart, go into the lungs. They go through the arterioles. As they go into the lungs, they get smaller and smaller. They become capillaries. They pick up the oxygen. Then they head back to the heart through another set of venules and veins back to the heart. Okay? So there's really two sets of, there's two circulations that we're always talking about here. Vessel walls, what are the pipes like? Well, they have three layers. We call them, they're really complicated to name. They're called the tunica intima, the tunica media, and the tunica externa. Tunica means tunic, like a coat, like a layer. Okay? The tunica intima is the innermost one, also called the endothelium. The endothelium is the endothelial lining that I've already talked to you about before because it can resist clotting and allow the blood to slide by it. It has a connective tissue layer. It also has an internal elastic membrane. And I have to tell you right now that when you're looking at these things under the microscope, it's this internal elastic membrane that stands out and is pretty obvious a lot of the time to, let me get that arrow out of the way, to help you decide whether it's an artery or a vein. Now remember that the arteries are getting blood straight from the heart and it's under pretty good pressure. So arteries are thumping and they're pumping and they're exposed to a lot of pressure. And that's why, when you put your finger on your radial artery here, you can feel your pulse. You're actually feeling the beats of the heart pumping the blood, and it causes your arteries to expand a little bit, and then they come back to normal size. Waiting on the next heartbeat, then they get big again and go back. By the way, if you're looking at an aorta, and you're looking at one of the really major blood vessels, you can actually see them getting bigger and smaller. These you can just kind of feel it, but others you can see it. The tunica media is the middle layer. The middle layer just contains a bunch of smooth muscle, so it's the one that's going to clamp down to send less blood to an area. And obviously it holds the inner and the outer layers together. There is an external elastic membrane in the tunica media. But here's the thing that I think is most important that you know. The tunica media is where, in the medial part of the blood vessel walls, is where arteriosclerosis forms. It's where the cholesterol is laid down that's going to narrow the arteries and lead to most of our death, either in our coronary arteries causing us to have heart attacks, or in our neck arteries causing us to have strokes, in our kidney arteries causing us to have kidney failure, in our legs that will cause us to have amputations. All of those things are all vascular diseases caused by narrowing of the arteries, by buildup of cholesterol, and when it builds up in the tunica media. The outermost layer is called the tunica externa, oftentimes referred to as the adventitia. Remember, we had an adventitia around the esophagus. Actually, we haven't gotten to that yet. But around the esophagus, it doesn't have a peritoneal covering. You'll hear that word adventitia a lot from here on in, I guess. Anyway, it's just kind of a bunch of layers of connective tissue. They're kind of disoriented, and they have little blood vessels going into them called the vasa vasorum, which, as you say here, says the vessels of vessels. And just like the heart muscle itself has to have coronary arteries carrying blood to the actual heart muscle of the pump, some of these biggest arteries are so thick, and you've seen them on your hearts, the aorta, you see it's that thick. Well, it can't just diffuse oxygen into that. So they actually have little blood vessels that carry blood into the wall of the aorta and to the large vessels. And those are called vasa vasorum. And they basically just supply the cells of the wall of the blood vessels with oxygen and so forth. Does that make sense? Okay, here's some pictures. These are pretty good, actually, I think. Think of this as an artery on this side. Think of this as a vein on this side. Here's a picture in the middle, shows an artery right here. Arteries are usually always round, even under the microscope. The reason they're round is because they have all these elastic layers in them that kind of pull them together, so they're round. Veins have very thin walls, relatively speaking. They're also bigger, so that you actually have a lot more blood in your veins at any one time than in your arteries, just because the walls kind of relax and it serves as a place for blood to sit around and stay. Looking over here at the artery, here's the three layers: the intima, the media, the externa is this kind of loose adventitial layer on the outside. But please notice this, here's the endothelium, which remember is simple squamous, right? Simple squamous epithelium. And then there's this elastic layer, the internal elastic membrane, which you see there. And it's kind of got this very universal squiggly to it of the elastic membrane as it's contracted. And so that's going to go in and out with each heartbeat. But when you look at it under the microscope, this elastic membrane is usually quite visible. And it's also what we would call refractile. You know, it refracts the light as it comes through it. So if you get look on an artery under the microscope and you go down here and grab your fine focus and kind of move it back and forth, the internal elastic membrane will kind of blink at you as the light gets refracted as you move that fine focus a little bit back and forth. Okay? If you don't see that, call me over, I'll show it to you. So that's pretty much it. Notice that there is this elastic membrane here on the inside in the inner layer of the tunica intima, and there's another one out here on the external elastic membrane. Believe me, it's a lot less obvious than the inner one is. Here's what a vein looks like. It's a lot thinner, actually. It has an endothelium, which is also simple squamous epithelium. It has some muscle in the wall, but not near as much as the artery did. It has a tunica externa or adventitia around the outside of it. But I think the main thing is it doesn't have all the elastic fibers. It doesn't have the elastic membranes. Veins are pretty floppy. They can open and close, and they're not rigid. They don't carry any significant blood pressure in them. You know, the blood pressure in an artery will be, you know, like 120 over 80. Blood pressure in a vein is probably going to be 8 over 0. Very low blood pressures in veins. The blood is just trying to get back to the heart. Okay, so vasoconstriction and vasodilation. Basically, you've got it all been vasoconstricted before if you were in the cold wind outside and your face is starting to get cold. You're going to vasoconstrict. All the blood vessels in the skin are going to shrink down. You're going to look really pale or white, and that's because you don't want your body sending a bunch of blood to your face when you're outside, because if you send a whole bunch of blood here, it's just going to radiate that heat, and you're going to lose that heat, and you're going to get colder. You're going to get hypothermia. So that's an example of vasoconstriction. And vasodilation is just the opposite. That's when you're inside and you're nice and warm and your skin is all red and your blood vessels are all vasodilated, and that shows that you're sending lots of blood to that particular area and you're radiating the heat off of you. Okay. Now, this vasoconstriction and vasodilation, I want to talk about that in terms of afterload on the heart. I talked to you guys the other day about the cycle, the cardiac cycle. And if you remember on the front side of the systolic heartbeat, the pressure is way down here low in the ventricle. And then it starts on this really big steep rise. Remember that? And when it gets about 2/3 of the way up that slope, there's a little notch right there, a little bullet point that says that's where the aortic valve opens. Okay? So sure enough, the pressure is now built up enough that the aortic valve opens, and then it keeps going up a little bit higher, and that's as the blood pushes out of the heart up into the aorta, and then it comes down, and as it comes down a little bit, it goes boop, and there's another bump, which is called the dicrotic notch. And the dicrotic notch is what happens when the blood comes back and it causes the aortic valves to slap shut, and that gives you an extra little hook there in it. If you put in an arterial line, and I know that some of you who work on ambulances and in emergency rooms and places like that, I'm sure have done that, or at least seen them. God damn it. Excuse me.
I'm just gonna start bringing my markers.
That would be really nice if you would do that, because, you know, generally there's a set in here, but, well, here's a couple. All right, so here's what an arterial line tracing looks like. It looks like this, comes down, and there's a little notch in it right there, like that. And that little notch is called the dicrotic notch. And that's where the blood is all shot up out of the heart. The aorta has expanded. Now it's through shooting, and it comes back a little bit. The aorta contracts down on it a little bit. Blood flows back just a little bit, and it snaps that aortic valve shut. And that's what this is right here. This is called the dicrotic notch. Notch, N-O-T-C-H. Okay. Now, the other point that I wanted to make, and I thought about this the other night, but because I didn't emphasize this point to you. I talked about afterload the other day when we were talking about the cardiac cycle. And afterload is the amount of strain that is on the heart. And afterload is not a good deal. And so if you looked on this side of the big, this is the LV pressure, remember? And you remember that up here was the aortic pressure. And aortic pressure kind of came down like this till it got to about 80. So here's about 80, okay? And then at this point, this is when the aortic valve opens. So the AV, no, not AV, the aortic valve opens. And once that aortic valve opens, then blood can actually start flowing out into the aorta, right? And that's really what the heart's all about. It's about pumping blood around, right? Afterload, the definition of afterload is how much load is on the heart kind of all the time. Now, let me draw this picture for you. If this is, let's say the patient has a blood pressure of 120 over 80. And that means that this pressure up here is 120, this pressure down here is 80, right? And it wasn't until the muscle of the heart, the muscle in the walls of the left ventricle generated this pressure up to this point here before it actually opened the valves and actually started blood flowing, okay? And then when he gets up here, the heart is kind of shot, it's wide, and now the blood comes back a little bit, and so all of the ejection of the heart is going to take place between there and there. You can buy that? Now, let's just say you had high blood pressure. Let's just say instead of your blood pressure being 120 over 80, which is really normal, your blood pressure was 150 over 110. Okay? So now what's the difference? Well, first of all, I'll tell you that the biggest problem is your heart has a whole lot more afterload on it. It has a whole lot more work to do. And why is that? Well, because now, here's the heart starting to pump. It gets it up here to 80, but that doesn't open the aortic valve yet, does it? It has to keep on going up until it gets to about here. It's pushing that much harder. It's got this afterload on it. It has to increase the pressure up here to 110 until the aortic valve opens and you actually start blowing blood out, okay, until you actually start pumping. So your heart has had to generate an extra 30 millimeters of pressure with every single heartbeat to make blood move, okay? Now, sure enough, the heart is going to work really hard, and in order to empty itself, it's going to have to push it up to 150 here. But this is really what afterload is about, and this is really what high blood pressure is all about. This is why you don't want to have high blood pressure, because every heartbeat, your heart has got to work. It's got to generate that pressure up to whatever your diastolic number is up here, whether it's 80, which is normal, or if it's 110 or 120. It's got to generate all that extra work before one drop of blood flows out of your heart. Okay? So when you read the word afterload in your going through that chapter and going through that cycle, that's really what I'm talking about. That's what we're talking about, is afterload on the heart is resistance to flow. Okay.
Could you tell us more about the 150 then? So if the valve's open at 110, why does it?
Well, because the heart wants to empty itself.
Okay, how about if it was 190 over 90? Could it be that?
Yeah.
Okay, so what would it look like then? It was
Be the same thing. It would have to generate up to 90 till the valve opened,
right.
but then it has to go all the way up to 190 before it's actually pushed it all out. Now, the reason it might be 190 is because those blood vessels, the aorta, maybe it's calcified, maybe it's really hard. In an old person, the blood vessels, the aorta, for example, doesn't expand with each heartbeat anymore. It just stays like a rigid pipe because it's all calcified. And so the pressure will shoot a lot higher.
To make sure that all the blood.
Well, you still want to, you've got to eject an ejection fraction to make anything happen, right? So, yeah. All right. I'm sorry I kind of digressed there, but anyway. I'm sure you'll never forget what I just said, right?
Doesn't the muscle of the heart thicken too, as you with high blood pressure?
Yeah. What the muscle of your heart does, it works harder because it wants to. Because it's got these controls on itself that say, hey, wait a minute, we got to pump this much blood. We've got to eject a certain amount. We've got to eject this ejection fraction out. We're going to come back to that. Okay. So peripheral blood pressure is obviously what we're talking about here, depending on how much vasoconstriction there is. Capillary blood flow is the amount of flow that goes through the capillaries, which is really, when it all comes down to it, this is really what the whole idea of the cardiovascular system is. It's to pump enough blood to all the capillaries in your body that then service all the tissues of your body. Make sense? So, as you leave the heart, and you head out to the capillaries, the arteries are going to change, and they change a lot. The first ones, the big ones, as they come out of the heart, they're very elastic. They're called elastic arteries, and you can actually see them get bigger and smaller with each heartbeat. Okay. As they go farther on out, say they're going down your arm here, they become more muscular. They have a lot of muscle in the wall of them that controls the amount of blood flow that might flow to that part on downstream. And indeed, it's the arterioles, which also have blood muscles in them, that are the last ones before they really get small and become capillaries. Arterioles are really kind of where it happens. I think I mentioned that before. Arterioles are pretty small. They can change depending on sympathetic or endocrine stimulation. Think sympathetic, think fight or flight, think epinephrine, right? Think tiger in the room. The more constricted the arteries are, the more opposed to blood flow that is, and that is called resistance. And that's why we call the arterioles the resistance vessels. For example, the tiger walks in the room, I get this big rush of adrenaline, I get this big rush of sympathetic tone, and that sympathetic tone says, well, wait a minute, we're going to be fighting or flighting that tiger right there. So we don't want to be sending blood to things we don't need to send blood to. Let's quit sending blood to the stomach. And suddenly the arterioles of the stomach clamp down, and you're not sending hardly any blood to the stomach anymore. The arteries of the kidneys clamp down and you're not sending any more blood to the kidneys for a while. Okay? Now, that's a good thing because that frees up the rest of that blood to go other places, right? It also, because you've now got all of these different beds of blood flow beds closed off, it generally raises your blood pressure, which is also a good thing if you're facing a tiger, to have your blood pressure up there so everything is ready to react full speed. Yeah. An aneurysm, aneurysm is a bulge in an arterial wall. The most common kind of aneurysms are located in the aorta, what we call infrarenal aorta. So if here comes the aorta down, here's the renal arteries going to a kidney on one side, going to a kidney on the other side, and starting about 2 centimeters down here is where most aortic aneurysms occur, and they bulge out like this, and then they come down here and divide into the iliacs and go down your 2 legs. So they occur right down here. This is an AAA, an abdominal aortic aneurysm. We used to operate on them when we found them. If they were big enough was 5 centimeters, about this big. And usually you could diagnose them on physical exam simply by putting your hands on somebody's tummy down here right below their belly button, and your fingers would go plump, plump, plump. And if indeed your hands were going this way, that was usually the sign it was an aneurysm. If you just felt the pulse and your fingers would go this way, that was pretty normal. Yeah. And the surgery to fix an aortic aneurysm was you go in there, you give them some blood thinner, you put a clamp across here, you put a clamp across here, you cut into the aortic aneurysm, lay it open. Any little blood vessels that might be coming in from the back side, you oversew so they can't bleed out. And then you take and sew in a piece of cloth, a piece of Dacron cloth that goes right in here. You sew it in down at this end as well. And so now the blood comes down through here. At the end, you take all the clamps off, obviously, and the blood flows through a tube down here instead of through this weak wall. And that is a pretty cool thing because those folks, if they're 5 centimeters, they have about a 5% per year chance of rupturing. And when people have a ruptured aortic aneurysm, that's a calamity. They usually die, unless they're pretty close to the hospital. Occasionally they'll get to the hospital still alive, and we can still fix them. But so if it's bigger than 5 centimeters, the risks are worth it, and you get it fixed. Yeah.
What sort of symptoms would somebody who has one of those?
Usually they don't have symptoms unless it's rupturing. If it's rupturing, they get bad pain in their tummy and in their back. You'd like to find them before they get to that.
Yeah.
And you'll see a lot of these, there's advertisements on TV now about going and visiting this trailer that has an ultrasound machine in it. You can get your aortic measured. You can get your carotids examined to see if they're clogged up and things like that. Yeah.
Would CPR keep them alive longer, or would that just...
Well, CPR could help, but the problem is they don't have any blood in them. Because once this thing breaks, they fill up their tummy.
That might just bleed them out quicker.
Oh, maybe. But you got to do something. If they don't have any blood in their brain, they're dead anyway in 4 minutes. Yeah.
For this, like, what's bulging? Is it just...
It's the whole arterial wall.
Okay.
Yeah. Okay. And the problem with the aneurysm is it is being stressed on every heartbeat. It's getting bigger and smaller, bigger and smaller. And that's what gradually makes them get bigger. The other place for aneurysms, well, there's lots of places for aneurysms, but the next most common place is in the circle of Willis. I think we talked about that once before with an aneurysm that can be treated up there as well. So anyway, here's a little chart that talks about the differences between the walls of the things. If you start out here at the elastic artery coming out of the heart, we've got all of these elastic layers. We've got an intima on the endothelium is on the inside, They become gradually more muscular. There's not as much elasticity to them, not as much elastic layer. Then as they get smaller yet, they become arterioles. They still have a bunch of smooth muscle cells. They don't have any of the elastic stuff anymore. Then they become capillaries, and the book talks about continuous capillaries versus fenestrated capillaries. Fenestrated capillaries are kind of like leaky capillaries where the blood just kind of can leak out. An example of a place where that might happen would be into the bone marrow. Then they start coming back together and they form venules, which are very thin-walled and very small. Medium-sized veins might be like a vein you see under your skin here. And you see it's got an externa, media, and an endothelium, but once again, the layers are all pretty thin. And then we get to the large veins, which would be like the superior vena cava, the inferior vena cava. And you notice they're thicker. They have muscular linings. They're just getting thicker, and then they get back into the heart.
So then a medium-sized vein would be what you draw blood on and put an IV in?
Yes. So here's a picture of arteriosclerosis. This is a plaque that builds up in the media of the wall of an artery. So here's an artery that's cut across, and you notice that this is obviously the endothelium is on the inside, the externa is on the outside, the media is in between, and in this case you see the media, there's plaque here. Plaque is nothing more than cholesterol buildup. And gradually, if this gets big enough and thick enough, then it really starts impinging in here on the lumen. And so it was not uncommon for us to operate on arteries that were 99% occluded. In other words, just a tiny little stream of blood going through here. And this cholesterol had built in and closed it in from all sides, so there's just a tiny opening. And that's what you're bypassing around when you're doing heart surgery that we talked about. Capillaries, how do they work? They're small. They don't have any media really. They don't really have much in the way of an externa. Sometimes they're so small they're just an endothelial tube, as illustrated right there. They're just one cell layer thick. Continuous capillaries. I just wanted to tell you right now, don't make a big deal of this continuous capillaries versus fenestrated capillaries. I don't think it's very important. There are places where obviously the continuous capillaries, they do allow some water to fuse through the walls, but they don't let any blood cells or plasma proteins get through them, and that's a good thing. When we get to the kidney, we'll talk about some of this a little bit more in depth. One of the places that we have some kind of specialized capillaries is, remember, the old blood-brain barrier. The blood vessels that go up to the brain have kind of special capillaries in them that only let stuff through, some stuff through and others not through. Remember the cells called astrocytes, which are a type of glial cells, remember them? That function in the blood-brain barrier as well. Fenestrations, these fenestrated ones are the ones that have slits in the side of them, and they allow very rapid exchange. They let fluid and water and proteins move in and out. You find them in a few places that are where it would make sense that there's wide exchange of fluid. The choroid plexus. Remember where the choroid plexus is, Marcelon?
Yes.
Where is it?
It's in
That was the follow-up question. Yes, I expected.
third
Third ventricle? In all the ventricles, that's right. They all have a choroid plexus. Remember, the choroid plexus makes CSF. Okay, some of the endocrine organs, you just kind of pour blood out in them. They need lots of blood. The kidneys, as we're going to learn next term, we obviously go through and the way we make urine, by the way, here's a little prelude to you. The way you make urine is the blood flows into your kidney and tons of fluid pour right out of the blood vessels. And then we reabsorb what we want to keep. Okay? And what we don't pull back in becomes pee. Okay, that's the way we make urine. So we have lots of these fenestrated capillaries there, also in the intestinal tract, where we obviously have to absorb lots and lots of stuff. I think I'm just going to leave this. Bone marrow, endocrine organs, spleen, and liver. These are organs that are almost like big bags of blood. I think that's fair to say. A spleen, the bone marrow, blood is just kind of dumped into them. It sloshes around through the bone marrow. It does its thing, and then it goes back out through a bunch of little veins. So these are sinusoidal capillaries that you need to know about. One of the other things is that the bone marrow, I think I mentioned before, if you've got a kid and you're trying to resuscitate a kid and you can't get an IV because all the veins are contracted or not present, you can actually do an IO, an intraosseous line. You stick a line, screw a big needle directly through their, into their shin bone, into the bone marrow of their shin. And then once you've got that needle in there, you can just pour in IV fluid because you're entering into this big sinusoid. The whole inside of the tibia is just a big bag of blood, and it finds its way out. Okay, let's talk about capillary beds a little bit. I don't want to make too much of a big deal of this because I just think what this is, the capillary beds or the capillary plexus is, we've got blood coming down through smaller and smaller arterioles, and then it empties into capillaries, and then it goes through this bed, this area that it's going to supply, and then it starts collecting and gets into veins bigger and bigger to head out. Okay, well, we have some that are called thoroughfare channels. In other words, the blood comes in, the blood goes right through in a pipe, and the blood goes out. Okay? Others are different than that, and they get really tiny, and they act as exchange vessels. So this is a diagram, which is strictly a diagram, by the way, of arteries coming in, arterioles coming in to this capillary bed right here, and you notice that this is what they call this a met arteriole, which is kind of a thoroughfare channel. So any blood that flows through here just kind of goes right on through and heads right back up and goes back to the heart. And then some of it goes on and goes through these little, here's an arteriovenous anastomosis, which is a pure thoroughfare coming through there. And then all of these little ones have little sphincters on them, little precapillary sphincters that can be closed off if you want to send blood to this area, and they can be left open if you want, closed off if you don't want to send blood through all these little capillaries, open if you want to send more blood to that area. I just think that this is kind of just diagrammatic. The key over here says if it's got a straight line, it's just continuous blood flow, as illustrated here. And if it's dotted like this, it's variable blood flow. And that's all determined by the amount of muscle that's in the wall of the arterioles as to how much you let go through there. Here's a nice microscopic picture of the same sort of thing, showing a small artery coming in and it filtering through all these little tiny blood vessels. I don't know. Capillary sphincter is just like any other sphincter. It closes it off. It allows, it guards the entrance to each capillary, and it can open or close, allowing the blood to either go in there or not. Veins are on their way back to the heart. It collects the blood from the capillaries, sends it back to the heart. In general, they are larger in diameter than the arteries. Now, that doesn't mean it carries any more blood, because it's under a lot lower pressure in the veins. So it sort of has to have more volume, more size, in order to carry the same amount of blood than is carried through those smaller arteries, because remember, they're pulsing, they're at really pretty high pressure. So they have thinner walls, lower blood pressure, larger in diameter than arteries. The valves, there's really no pumping system to pump the blood back. So if blood comes down through your arteries and it goes into your toes, for example, and now you put it into a pipe called a vein that's got to come all the way back up to your heart, that's a lot of gravity to rise against. And you'd think your body would install sort of little helper pumps along the way to help it get all the way back up. Otherwise, what would happen is your legs would probably swell a lot, and that happens to a lot of people. Now, how does it work? Well, this is the way it normally works, and that is that your veins down in your legs, back between your foot and your groin right here, usually you have about 4 sets of valves. And so the blood can come up through these valves and then it closes off, so it can't really go back. Now, what is it that pushes it up through those veins? Well, it's the contraction of the muscles of your legs. So every time I take a step across the front of the room, my muscles are squeezing the veins in my leg. They're pushing all the blood up through these valves, but it can't go back because when it tries to go back, the valve's shut. Make sense? So that's what we call the muscular pump of the venous system in the legs, and it really helps get all that blood and fluid up out of our feet. Now, you've ever heard the term phlebitis?
Mm-hmm.
What does that mean to you?
An inflammation of the vein.
Oh, really? So what? So what if your vein gets inflamed? What's the problem?
Blood can't go through it.
What?
The blood can't go through as easily.
No, it can.
Does
It
it
can.
have something to do with the valves not working properly?
Yeah, the problem is when the inflammation gets in these valves, I mean, you won't believe how thin these tissues are. You can see through them, they're so thin, these little valves in the veins down here. So if this gets inflamed, and that's usually caused by a blood clot that forms, somebody got a thrombosis, clot in their leg, and then they got phlebitis, which is an inflammation in the area as your body reacts to this clot that shouldn't be there. And these valves then get inflamed, and so now instead of coming together nicely like they should, they don't. They kind of go like this, and they don't match up. And so blood goes up through them, and blood goes back down through them. Blood goes up through them, back down through them. And so those folks who have had phlebitis, chronic phlebitis, are the ones who you see with the really swollen legs down here. That's the sign of chronic phlebitis. Their sign is they get dark spots, kind of splotchy looking things on their lower legs down there. How does that get better? It doesn't. All you can do is treat it, and usually you treat it with support stockings, and then a lot of people at nighttime they go to bed with these basically balloons on their legs that are big things that are a machine pumps them up and lets them down, pumps them up and lets them down in order to help ease all any extra fluid out of their legs. You see us put those on everybody in surgery, because when you're in surgery, you don't move a muscle. Truly, you get paralyzed. You're laying on an operating table for 2 or 3 hours and you don't move a muscle. So the blood in your leg veins just sort of sits there, and that's a common place where blood clots form that then break loose after surgery and go to the heart and stop the heart. That's why most every patient at least will get support stockings or inflatable compression stockings put on their legs before surgery. Yeah?
So those valves are operated by our leg muscles contracting.
No.
Is that what you said?
No, the only thing that makes them work is that when the muscles contract out here, they push all the blood out of this piece of vein, push it up through the next one, and then it just snaps shut.
So what about when they're not contracting?
So they're not contracting,
Just sitting here.
the blood's just sitting there.
Okay.
Moves very little. Another reason to take your aspirin a day, because an aspirin a day thins your blood a tiny little bit and prevents clots forming. We take anybody over the age of 50 in America probably ought to be taking an aspirin a day just to prevent little strokes and problems, but also this. This is why people get blood clots in their legs when they travel on long airplane rides. Okay? And why whenever you go on an airplane, you should get up out of your seat every 30 minutes and walk around a little bit, or at least do some bunch of exercises on the seat in front of you. Really piss off the person sitting there. Yeah.
Is it harder on you to have a desk job or a job where you stand all day?
I don't really think that matters as long as if you have a desk job, you get up and move around. Okay. Where is the blood in our body at any one minute? Okay? So if you could instantly stop your blood flow,
That'd be freaky.
yeah, but if you could stop your blood flow right now, where is the blood? Okay, that's what we're talking about now. Where is it? Well, only about 30 to 35% of it is found in the heart, the arteries, and the capillaries, which means that the rest, about 50 to 65%, or about 2/3 of it, is found in the venous system, okay, in the veins. Remember I told you veins are bigger because they're under really low pressure. So a lot of it is in the big veins, but then a lot of it is also sitting in those sinusoidal capillary things we just talked about, like the liver, the bone marrow, and the skin. Another term you need to understand is called capacitance. Capacitance is the ability to stretch. Okay? And it has a great deal of relationship between blood volume and blood pressure. For example, if you had blood in your veins and you could compress it a little bit, or you need to put more in there, the veins, because their walls are very thin and they aren't muscular, they have great capacitance. They can just open up and take on more blood. Okay? They have no pressure. Whereas arteries and arterioles are not capacitance vessels. They've got enough stretch and elasticity and muscles in the wall that they're not going to be capacitant and allow extra blood to fill them up more. So what happens when we bleed? Okay? So you're walking down the road and you get run over and you bleed about 2 pints of blood out on the ground. Okay? Why don't you just die? You're missing 2 pints of blood. That's a lot, right? It's a whole quart. It's a whole liter. My God, it's this much. This whole thing is a liter. You've lost that much blood. What's going to take its place?
There's going to be constriction. Some things are going to.
Oh, really?
Yeah.
There's going to be.
Those right there. We know constriction.
That's right. The veins, which suddenly don't have any blood or don't have enough, they're going to constrict so that you make the best of what you got left, right? And the arteries can contract down a little bit, but not much, because remember, they only have, 30% of all the blood is even in the arteries and the heart. So we have to figure out how can we make up the difference if we lose blood? And basically it happens because a lot of these bigger veins that are out in our body, in our arms, even these ones in our arm here that I can see in me, for example, they're going to shrivel up big time. They're going to constrict, and you're not going to be able to see any veins on my arm if I've lost a pint of blood or 2 pints of blood. That's why resuscitation is so hard. When you're trying to take care of somebody who's been bleeding from a car accident, and you get them over and say, oh, I'll just start a little IV on them. There ain't no veins. You can't see a thing. They're all shriveled up. They're all vasoconstricted as much as possible to make up for the blood they've lost.
And that's why it's better to do an arterial line or something of that nature, because the arteries can't constrict as much as the veins can.
You would never use an arterial line to give people stuff through. You use arterial lines just to measure their pressure. You might do an IO into the bone, but you've got to find a vein. Okay. I don't know if I want to think I've told you the story, but I think when things make a huge impression on your life, they never go away. And I always remember the time that I was in the emergency room in the John Gaston Hospital, the city hospital in Memphis, Tennessee, and the ambulance rolls in, and there's firemen everywhere, and there's everybody. And there's this guy on the table who looks dead. And we all and I was a medical student, I kind of stepped back a little bit and said, I don't want to get in the way, because there's a lot of these people that know what they're doing. And this young intern who was a smart guy, he sort of took control, and he said, okay, put him in Trendelenburg, which means put his feet up higher than his head, and give me an IV. And he got one of these big, huge IV needles, and he took the guy, and he felt his neck, and he felt for the edge of his sternocleidomastoid, and he tried to feel for his carotid artery. And you should all be able to feel your carotid pulse right there, but I bet, I can feel mine, I'm still alive. And then he just took this big needle and went, boom, right in there, just like that. Just medial to the sternocleidomastoid, just lateral to the carotid pulse. I don't think he even had a pulse on this guy. But he, boom, stuck it in. Immediately he had a huge IV. We stuck a huge IV into the guy. Hooked up a big tube, started running blood, started running IV fluid, started running drugs, and the guy came back to life. And I'm thinking, and I've always remembered that little 5-minute episode as thinking, geez, that guy did what he just did because he knows the anatomy. He knew where that vein was, even though you can't see the jugular vein, and I can't see the jugular vein in anybody, but he knew where it was because he knew the anatomy. He knew where the sternocleidomastoid was, he knew where the carotid pulse was, and he just stuck it in blindly and got it. Now, I never did get very good at doing jugular sticks, I'll be honest with you, because I got really good at doing subclavian sticks. And you'd lay somebody down on the table, and you'd take a big ass needle and stick it right under their collarbone right there, and aim it for their other shoulder, and you'd hit the subclavian vein, one of the big veins that goes this way. And they were great too. But that jugular vein I always remembered it. Yeah?
What's a central line?
Central line just means a line that's anywhere that the tip of the line ends up in the central circulation, either in the jugular or subclavian,
That's what I was thinking.
or in the heart. A lot of the times when you stick a line in somebody's subclavian and you feed the catheter in, you're feeding the catheter actually down into their heart. What does it really mean? It means that when you have a line in the central circulation, it's not like being out here. When you stick a line in out here and you run in some fluid, then the stuff that's in that vein there is mostly the fluid you just ran in, right? And so if the stuff that's in that IV bag is irritating in any way to the inside of the patient's veins, it's going to get real painful, and as a result, you can't inject a lot of stuff into a peripheral vein. But in the central system, you've got this tube that's going into one of these big veins, and it's like a tube sitting in the middle of a fire hose. And whatever you run in here, there's so much blood going around it that it's instantly diluted, and it won't do damage to the veins. That's really what central vein means. Okay. So, venous response to blood loss, the veins that are still there are gonna, the vasomotor centers are, you're getting ready to fight that tiger. You just bled a bunch of blood. You're in a stress situation. Sympathetic, fight or flight, all your blood vessels collapse down and squeeze down, trying to allow you to still maintain a blood pressure with the blood you got. Most of that vasoconstriction occurs in the venous system and causes this major redistribution of what we call the venous reserve. In other words, there's a lot of blood that's just kind of sitting around in your veins all the time that you could do without. So when you lose other blood, you can squeeze down those veins and push it back sort of into the real circulation and where you start using it again. Okay? Overview of cardiovascular physiology. I think here's some terms that you need to understand, and a lot of these terms will become crystal clear to you when you do the physio-X's. Okay, the physio-X's are basically a series of little exercises in cardiovascular physiology. What helps control it? Well, obviously, a neural and hormonal, the epinephrine from the suprarenal glands, the epinephrine released by the hypothalamus, and that can increase the venous pressure, which then can increase the venous return, the amount of blood that's returning to the heart. And the more you have returning to the heart, the more you have going out. Because remember Starling's law of the heart, the more in, the more out, right? The more blood you have in the heart, the more it will pump. Arterial blood pressure can go up by simply squeezing down on the arteries and increasing the peripheral resistance. Fluid can go either in or out of the capillaries through capillary exchange. Obviously, if you're sitting around and everything is cool, you kind of like to have fluid around your cells in your interstitial spaces. But if you really needed the fluid, you would immediately suck it back into the bloodstream and use it as plasma. So that's what this is down here, the interstitial fluid in harmony with the going in and out of the capillaries down there. Let's talk about a few little fancy terms that you'll become familiar with as you do those physio-X's. One is called pressure. Well, obviously, everything flows because of pressure. So if the pressure is high inside the heart, that will blow the valves open and cause the blood to flow out. Okay? The same thing goes through all the way around the circulation. It continues to flow out into the veins as long as the pressure in the arterioles is higher than it is in the capillaries. So it keeps flowing down, flowing downhill. This thing called the pressure gradient is what is the overall change of pressure. Well, let me just tell you that the entire systemic pressure gradient is the same as your systolic pressure. In other words, when your heart pumps and it blows that blood out into your aorta, it's at 120 millimeters of mercury. It's going to go down, that pressure is going to go down as it goes out into your system. It's going to go down, 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 down. When it gets out into your fingers, it's still going down, but it's not zero yet. It goes through the capillaries, it starts regrouping, it starts coming back up. Is it still positive pressure? Yeah, it's still positive pressure. That's still what's making it flow back, is that same 120 that it started with is still being burnt up as it's flowing back to the heart. So, the circulatory pressure is the pressure gradient. It's the pressure at the heart and the pressure at the peripheral capillary beds. Obviously, there's going to still be some significant pressure when it gets to the capillary beds because it still has to flow through all the veins on the way back, doesn't it? This is a thing that you have in your book that is just wrong. It's in the slides that came from the book company. It says force F is proportional to the pressure difference. That is not right. It's not force, it's flow. Okay? The more pressure change there is, the faster it's going to flow. That's easy enough, isn't it? Just realize that that is a big misprint, and I think it even used to be in the book itself. But flow is proportional to pressure difference. Divided by R, what's R? Resistance. Okay, so it depends kind of on how hard the vessels are squeezing. Let's talk about a few more numbers that you need to be able to understand in order to understand how this blood flows around. One is the blood pressure. Blood pressure is what we think of as arterial pressure. It's the cuff pressure that you measure at your arm here. And it's normally 120 over 80. Okay? Now, if you put a catheter into your radial artery down here and just have the catheter sticking straight up into the artery, and it's basically measuring that blood pressure, it'll give you a graph that looks like this with the dichrotic notch in it. So if you ever go into your grandma's ICU bed and visit her, and she's got an A line in, an arterial line in, it'll look like this. And that's that dichrotic notch of the aortic. I mean, it's and if you look on the graph here, this would be 120, and this would be at the 80 line. And usually it's all digital readouts these days. It just prints it out there for you, exactly what the blood pressure is from second to second, which is nice if you're in an ICU situation. Capillary, so blood pressure, capillary hydrostatic pressure is the pressure down in the capillary beds. It's all that's left is the pressure in the capillary beds, but it's the hydrostatic pressure. Now, I always have to make a point of this. When I say hydrostatic pressure, what are we talking about? When I say hydrostatic pressure, Ms. Garside, I know you're looking down really hard. What's hydrostatic pressure mean? Hydro is water, yeah. So what is hydrostatic pressure? Because you kind of got to think of it, Montiel.
When it's not moving?
When it's not
Pressure
moving?
When nothing's moving?
No.
Could it be referring to?
When you, well, let me just give you an example. When you go to your hose outside and you're at your house and you open the valve up, the water comes out under pressure, right? And what generates that pressure?
The water itself being like, kind of like a dam.
Opening of the valve. So you mean the pressure in the water lines? There's pressure in the water lines. What gives the water pressure? The water tower. That's right. In America, we get pissed off if the pressure is different on the second floor of our house than it is on the first floor. We like to have good, strong pressure, right? Because when you take a shower, you want that water to just beat on you, right? And so we have water towers. And the water towers are up there, 150 feet, and that is creating a hydrostatic pressure of 150 feet. Now, we don't usually measure water in feet of water. We usually measure it in millimeters of mercury, right? You guys, when you go listen, well, blood pressure, 120 over 80 is 120 millimeters of mercury over 80 millimeters of mercury, right? So what does that mean? 120 millimeters of mercury. Well, 120 millimeters of mercury is about how far? 120 millimeters. Millimeters are about that big.
1.2 centimeters.
How about 10 centimeters, which would be 100 millimeters?
I'm sorry.
So it'd be about this high, okay? So that's how high a column of mercury would be. Have anybody ever played with mercury? You're not allowed to do that anymore. Well, as a kid, we used to play with it all the time. My granddad brought home a big bottle of it one time from the school, and we played with it. It was a lot of fun. Probably got a little mercury poisoning, but I don't know. Seemed to have survived it okay. But mercury has 13 times the density of water. So if you took a square box of water and a square box of mercury, the box of mercury would weigh 13 times as much. So therefore, you don't have to have a column that's quite so high. And what that enables us to do is to make a sphygmomanometer, a blood pressure cuff, with mercury in it that only has to be about this tall to measure blood pressure. If you had water in there, it would have to be 13 times taller, and that wouldn't fit in your doctor's bag. Okay. Now these days, they don't even use those anymore. They mostly just have a little gauge that measures pressure, right? All right. Okay, so hydrostatic pressure just means what you think of as pressure. In other words, how far will it squirt? How much pressure is coming down on it? Venous pressure is always really a little bit, and there's this circulatory pressure, which I told you is the whole system. And there's this total peripheral resistance, which is the total amount of friction in the system. Now remember that the stuff that's flowing through these tubes is not water, right? It's blood, and blood is thicker than water. I think there's a song about that. Blood is thicker than water. And so therefore it doesn't flow as quickly or as easily as just pure water was. And the friction causes vascular resistance. And that's due to two things. One is the walls of the blood vessels aren't perfectly smooth, so therefore the water kind of bumps up against it as it goes down. That causes resistance. And also it depends on the size of the blood vessels, okay? So when blood vessels are big, there's not that much contact with the walls, and there is not that much resistance. But when those blood vessels get really, really tiny, so that now the blood vessels, or the blood cells, are lining up one by one to get through there, there's a lot of friction with the wall of the vessels, leading to a lot of resistance. So what you're going to learn in your PhysioX is that there's a great relationship between diameter and vascular resistance. In fact, it's actually resistance rises exponentially as vessel diameter decreases. What does exponentially mean, Tristan? Yeah. So going from 2 to 3 in a regular system would be like going from 2 times 2, which is 4, to 3 times 3, which is 9, as it went up. It's going up exponentially. It's going up by the square of the number. Okay? So it's increasing a lot. When your vessels get small, it's making a lot of resistance. What is viscosity? Well, viscosity is just the thickness, the resistance to flow. Resistance is caused by the molecules and the suspended materials in a liquid. Certainly blood has lots of protein, blood has lots of cells in it, and whole blood viscosity, which is what we're pumping through our veins right now, is about 4 times as viscous as water. Turbulence? What's turbulence? I think I told you my little story about the Deschutes River. When you're going down the Deschutes River and it's nice and wide and the river's nice and deep, the water just kind of flows along and it's quiet and it just kind of moves you on down the river. But then you come to an area where there's a bunch of rocks in the river and the river gets narrower and suddenly the river is going really fast and there's all these currents and all these eddies and all this stuff. And that's all turbulence. The blood's going in different directions. Also, it's a swirling action that disturbs the smooth flow. It also causes murmurs, noises, okay? And indeed, it can occur in the great vessels. A lot of times, arteriosclerotic plaques will cause abnormal turbulence. In my office, I used to get 3 or 4 patients every week that were referred to me by a family doctor, and he said, Dr. Sessions, would you please evaluate Mr. Jones because he has a bruit in his neck, B-R-U-I-T. And sure enough, you'd take your stethoscope, you'd hold it up on his neck, over his carotid artery here, and you would hear it going, ch, 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 ch. That's called a bruit. And a bruit means that there's an atherosclerotic plaque in there. It's probably narrowed down to a certain degree, and you can hear it, okay?
And that's when you can have a stroke.
You can. The correlation between a bruit and a stroke is very low, though.
Oh.
It's much more important. That's why what we would do is just scan them with ultrasound and see whether they really did have much stenosis. It was the stenosis that leads to the strokes. So we'd say, well, you'd send a note back to the doctor and say, well, Mr. Doctor so-and-so, I evaluated your patient. He only has an 80%, he has 80% open, only 20% narrowing. The bruit, I think, is caused by the bifurcation of his carotid where it splits. I don't think it's anything to worry about sending him back to you.
So like an innocent heartburn where you could have an innocent
Exactly. Good point. Okay, so here's a bunch of numbers you ought to look over. You ought to be able to define every one of these because they will make sense, especially when you're doing those physio X's, venous pressure, vascular resistance, turbulence, and so forth. I think I've talked about all of them. There's a couple of relationships that you need to understand. Flow is proportional to the pressure gradient. Obviously, if the pressure here is 120 and the pressure there is 80, it's going to flow like crazy between those 2 points. If the pressure here is 120 and the pressure here is 0, it's really going to flow like crazy, right? So it all depends on the pressure gradient. Flow is inversely proportional to resistance. As the resistance goes up, the flow goes down. Make sense? Flow is directly proportional to the pressure gradient and inversely proportional to the resistance. Just putting those first two together gives you this one. I think I've said enough. This one's the kind of the real funky one here. Resistance is proportional to 1 over the cube of the radius. So resistance is inversely proportional to the 4th power of the radius. So as you lower the radius of the opening, it goes up by a factor of 4. The resistance does. I think I'll stop right here on overview. Cardiovascular pressures. Okay, I got a few more cookies up here. I want somebody to eat them because otherwise I have to take them home and eat every one of them. I don't need them.
Oh yeah.